patients with newly diagnosed non-small cell lung cancer, especially adenocarcinoma, now instead of waiting just to hear that it's cancer and just that it's adenocarcinoma, we need to have a lot of other information before we make the right first step into treatment. And that information is going to be particular driver mutations, so EGFR, ALK, ROS, BRAF in particular, but knowing the others can be helpful as well, though that information can wait. And then the PD-L1 level. The reason it's so critical is because if someone especially has EGFR or ALK, we know from multiple trials that they should start on the appropriate tyrosine kinase inhibitor instead of chemotherapy. And we know that the checkpoint inhibitors are also not a good first choice. If they don't have one of those and they have high PD-L1, we can consider giving them single agent checkpoint inhibitor, which is going to be better tolerated than chemotherapy or chemotherapy plus checkpoint inhibitor. Now with the Keynote 189 trial that came out in April of 2018, we know that across PD-L1 levels, patients do better with the pembrolizumab added to chemo, but at a cost of some toxicity. And so that is a very good option for many, but pembrolizumab alone, if you have high PD-L1, could still be a choice. And if you have high tumor mutation burden, there was, of course, the nivolumab ipilimumab option, so there's a few options there. Where it gets tricky is that the PD-L1 levels come first, and often first by even as much as a week or two before you get your EGFR, ALK, and ROS. And so there's going to be pressure when a patient wants to start yesterday. They've got a high PD-L1, just give me that checkpoint inhibitor, or the chemo plus the checkpoint inhibitor. But we have to be careful because if they have high PD-L1 and they also have EGFR, ALK, and those are not mutually exclusive, a lot of patients with high PD-L1 and with EGFR, ALK, if you start them on a checkpoint inhibitor, you're potentially harming them because they don't tend to benefit very much. And you can have toxic interactions between TKIs and the checkpoint inhibitors. So that's where it's so important to wait until you have the full story. Because this is our patient here, 73-year-old, has emphysema, some smoking history. He wasn't someone that was necessarily being considered as high probability of having EGFR mutation, and yet he does. And so if we had acted and just started him on treatment, we might have done harm. Now, chemo is fine, even if you have EGFR or ALK. Chemotherapy is not a wrong choice, it's just not the preferred choice. Patients with bone metastases who have a driver mutation often respond incredibly well to the tyrosine kinase inhibitors. In fact, they respond so well that we can get a phenomenon called flare, where it looks like there's worsening of bone disease even when it's getting better, and that has to do with the fact that there's suboccult disease that's not visible on scans. And as they respond, there's scarring, which becomes more visible. So I always warn patients about that. Then as we're trying to figure out how do we best treat the bone metastases, we want to think about if we need to add in any radiation. Rarely we have to ask a question around surgery, and that would only come into play if there's a weight-bearing bone, if there's a lot of pain. If someone doesn't have any bone pain, really we can just start them on the systemic treatment with the tyrosine kinase inhibitor and then think about adding in a bone agent. And the bone agents, of course, would be a rank ligand inhibitor like durvalumab, or a bisphosphonate such as zoledronic acid, Zometa. So those are the things that we think about when someone has bone metastases, but only in the setting of pain or weight-bearing issues do we feel like it's urgent that we have to add in other things. We will think about adding in the bone agents, but with a little bit of caution, we don't need to give full high doses of those agents. If someone's also getting a tyrosine kinase inhibitor, we might be over-treating and potentially even leading to bone loss and weakness.